Hi, Ruben here and welcome to Anatomy Movement, where anatomy becomes funatomy. We have summarized and detailed notes, acronyms, HD images to build your photographic memory, X-rays images, tabled notes and questions and answers at the end of each video to help you remember all that we have learnt. Without further ado, let's dive into today's topic. The bones of the lower limb. They include the femur, the patella, the tibia, the fibula and finally the bones of the foot. So let's break them down one by one. The femur. The femur is the only bone in the thigh and the longest bone in the body. It acts as the site of origin and attachment of many muscles and ligaments, and can be divided into three parts: proximal, shaft and distal. In this video we shall look at the anatomy of the femur, its attachments, bony landmarks, and clinical correlations. Proximal. The proximal aspect of the femur articulates with the acetabulum of the pelvis to form the hip joint. It consists of a head and neck, and two bony processes, the greater and lesser trochanters. There are also two bony ridges connecting the two trochanters, the intertrochanteric line anteriorly and the trochanteric crest posteriorly. Head articulates with the acetabulum of the pelvis to form the hip joint. It has a smooth surface, covered with articular cartilage, except for a small depression, the fovea, where ligamentum teres attaches. Neck connects the head of the femur with the shaft. It is cylindrical, projecting in a superior and medial direction. It is set at an angle of approximately 135 degrees to the shaft. This angle of projection allows for an increased range of movement at the hip joint. Greater trochanter, the most lateral palpable projection of bone that originates from the anterior aspect, just lateral to the neck. It is the site of attachment for many of the muscles in the gluteal region, such as gluteus medius, gluteus minimus and piriformis. The vastus lateralis originates from this site. An avulsion fracture of the greater trochanter can occur as a result of forceful contraction of the gluteus medius. Lesser trochanter, smaller than the greater trochanter. It projects from the posteromedial side of the femur, just inferior to the neck shaft junction. It is the site of attachment for iliopsoas, forceful contraction of which can cause an avulsion fracture of the lesser trochanter. Intertrochanteric line, a ridge of bone that runs in an inferomedial direction on the anterior surface of the femur, spanning between the two trochanters. After it passes the lesser trochanter on the posterior surface, it is known as the pectineal line. It is the site of attachment for the iliofemoral ligament, the strongest ligament of the hip joint. It also serves as the anterior attachment of the hip joint capsule. Intertrochanteric crest. Like the intertrochanteric line, this is a ridge of bone that connects the two trochanters. It is located on the posterior surface of the femur. There is a rounded tubercle on its superior half called the quadrate tubercle, where quadratus femoris attaches. Clinical relevance: proximal femur fractures. Neck of femur fractures (NOFs) are increasingly common and tend to be sustained by the elderly population as a result of low-energy falls in the presence of osteoporotic bone. They are more prevalent in women. In younger patients they tend to occur as a result of high-energy accidents. The distal fragment is typically pulled upwards and rotated laterally. This manifests clinically as a shortened and externally rotated lower limb. These fractures can be broadly classified into two main groups. Intracapsular, occurs within the capsule of the hip joint. It can damage the medial femoral circumflex artery, and cause avascular necrosis of the femoral head. Extracapsular, the blood supply to the head of femur is intact, so avascular necrosis is a rare complication. The shaft. The shaft of the femur descends in a slight medial direction. This brings the knees closer to the body's center of gravity, increasing stability. A cross-section of the shaft in the middle is circular but flattened posteriorly at the proximal and distal aspects. On the posterior surface of the femoral shaft, there are roughened ridges of bone, called the linea aspera, Latin for rough line. This splits distally to form the medial and lateral supracondylar lines. The flat popliteal surface lies between them. Proximally, the medial border of the linea aspera becomes the pectineal line. The lateral border becomes the gluteal tuberosity, where the gluteus maximus attaches. Distally, the linea aspera widens and forms the floor of the popliteal fossa, the medial and lateral borders form the medial and lateral supracondylar lines. The medial supracondylar line ends at the adductor tubercle, where the adductor magnus attaches. Clinical relevance: fractures of the femoral shaft. Fractures of the femoral shaft are typically a high-energy injury but can occur in the elderly as a result of a low-energy fall. They can often occur as a spiral fracture, which causes leg shortening. The loss of leg length is due to the bony fragments overriding, pulled by their attached muscles. As the method of injury is typically high energy, the surrounding soft tissues may also be damaged. Neurovascular structures at risk include the femoral nerve and artery. A closed femoral shaft fracture may result in considerable hemorrhage, 1000–1500 milliliters distal. The distal end of the femur is characterized by the presence of the medial and lateral condyles, which articulate with the tibia and patella to form the knee joint. Medial and lateral condyles, rounded areas at the end of the femur. The posterior and inferior surfaces articulate with the tibia and menisci of the knee, while the anterior surface articulates with the patella. The more prominent lateral condyle helps prevent the natural lateral movement of the patella. A flatter condyle is more likely to result in patellar dislocation. Medial and lateral epicondyles, bony elevations on the non-articular areas of the condyles. The medial epicondyle is the larger. The medial and lateral collateral ligaments of the knee originate from their respective epicondyles. Intercondylar fossa, a deep notch on the posterior surface of the femur, between the two condyles. It contains two facets for attachment of intracapsular knee ligaments. The anterior cruciate ligament (ACL) attaches to the medial aspect of the lateral condyle and the posterior cruciate ligament (PCL) to the lateral aspect of the medial condyle. Now let's have a quiz. 1. Which femoral bony landmark represents the distal anterior attachment of the hip joint capsule? Intertrochanteric line, pectineal line, intertrochanteric crest, linear aspera. The correct answer is intertrochanteric line. 2. Damage to which artery is most likely to cause avascular necrosis of the femoral head? Lateral femoral circumflex, medial femoral circumflex, artery to the head of femur, popliteal. The correct answer is medial femoral circumflex. The patella. The patella kneecap is located at the front of the knee joint, within the patellofemoral groove of the femur. Its superior aspect is attached to the quadriceps tendon and inferior aspect to the patellar ligament, bony landmarks. The patella has a triangular shape, with anterior and posterior surfaces. The apex of the patella is situated inferiorly and is connected to the tibial tuberosity by the patellar ligament. The base forms the superior aspect of the bone and provides the attachment area for the quadriceps tendon. The posterior surface of the patella articulates with the femur, and is marked by two facets. Medial facet, articulates with the medial condyle of the femur. Lateral facet, articulates with the lateral condyle of the femur. It is classified as a sesamoid-type bone due to its position within the quadriceps tendon, and is the largest sesamoid bone in the body. In this article we will look at the anatomy of the patella, its surface features, functions and clinical relevance. Functions. The patella has two main functions. Leg extension, enhances the leverage that the quadriceps tendon can exert on the femur, increasing the efficiency of the muscle. Protection, protects the anterior aspect of the knee joint from physical trauma. Clinical relevance, injury to the patella. Patellar dislocation. In a patellar dislocation, the patella bone is displaced out of the patellofemoral groove. It accounts for around 3% of knee injuries. Most dislocations occur laterally and are caused by high-force impact on the patella or forceful sudden twisting of the knee. These mechanisms of injury make patellar dislocation more common in individuals participating in sports such as football, rugby and ice hockey. Patellar fracture. Patellar fractures usually result from direct trauma to the bone, or sudden contraction of the quadriceps muscle. They are more common in males, and in the 20 to 50 age range. If the patella fractures into fragments, they will usually separate, the proximal fragment displaced superiorly by the quadriceps tendon and the distal fragment pulled inferiorly by the patellar ligament. Now let's have a quiz. 1. The patella is formed within the tendon of which muscle? Iliopsoas, adductor magnus, quadriceps femoris, semimembranosus. The correct answer is quadriceps femoris. 2. Which of the following attaches to the base of the patella? Patella ligament, gastrocnemius, posterior cruciate ligament, quadriceps tendon. The correct answer is quadriceps tendon. The tibia. The tibia is the main bone of the lower leg, forming what is more commonly known as the shin. It expands at its proximal and distal ends, articulating at the knee and ankle joints respectively. The tibia is the second largest bone in the body and it is a key weight-bearing structure. In this video, we shall look at anatomy of the tibia, its bony landmarks, articulations and clinical correlations. Proximal. The proximal tibia is widened by the medial and lateral condyles, which aid in weight-bearing. The condyles form a flat surface, known as the tibial plateau. This structure articulates with the femoral condyles to form the key articulation of the knee joint. Located between the condyles is a region called the intercondylar eminence. This projects upwards on either side as the medial and lateral intercondylar tubercles. This area is the main site of attachment for the ligaments and the menisci of the knee joint. The intercondylar tubercles of the tibia articulate with the intercondylar fossa of the femur. Shaft. The shaft of the tibia is prism-shaped, with 3 borders and 3 surfaces, anterior, posterior and lateral. For brevity, only the anatomically and clinically important borders, surfaces are mentioned here. Anterior border, palpable subcutaneously down the anterior surface of the leg is the shin. The proximal aspect of the anterior border is marked by the tibial tuberosity, the attachment site for the patella ligament. Posterior surface, marked by a ridge of bone known as soleal line. This line is the site of origin for part of the soleus muscle, and extends inferomedially, eventually blending with the medial border of the tibia. There is usually a nutrient artery proximal to the soleal line. Lateral border, also known as the interosseous border. It gives attachment to the interosseous membrane that binds the tibia and the fibula together. Clinical relevance, intraosseous access. Intraosseous access is a form of vascular access used in the emergency setting. It allows the administration of fluids, blood products and medications directly into the bone marrow. EO access is typically used in an emergency when intravenous access is not obtainable. There are 2 main sites in the tibia that are suitable for EO access. Anteromedial surface, 2–3 cm below the tibial tuberosity. Proximal to the medial malleolus. Complications of EO access include osteomyelitis, iatrogenic fracture and compartment syndrome. EO infusions should be discontinued when IV access has been achieved. Distal. The distal end of the tibia widens to assist with weight bearing. The medial malleolus is a bony projection continuing inferiorly on the medial aspect of the tibia. It articulates with the tarsal bones to form part of the ankle joint. On the posterior surface of the tibia, there is a groove through which the tendon of tibialis posterior passes. Laterally is the fibular notch, where the fibula is bound to the tibia, forming the distal tibiofibular joint. Clinical relevance. Fractures of the tibia. Fractures of the tibia are relatively common. There are 2 main types. High-energy trauma occurs predominantly in the younger population. Low-energy trauma or insufficiency fractures occurs predominantly in the elderly. Fractures most commonly occur at the shaft of the tibia, and are typically associated with fibula fractures. Fractures of the proximal tibia are known as tibial plateau fractures. The condyles may be broken and injury to the menisci and ligaments of the knee is not uncommon. These fractures are classified using the Schatzker classification, and if very displaced will likely require operative management. It is important to monitor patients for signs of compartment syndrome in the pre- and post-operative phases. At the ankle, the medial malleolus can be fractured. This is caused by the ankle being twisted inwards. Over inversion, the talus of the foot is forced against the medial malleolus, causing a spiral fracture. This rarely happens in isolation and typically the lateral malleolus is also fractured, potentially producing an unstable fracture that requires operative management. Now let's have a quiz. 1. Which bony landmark of the tibia is the site of attachment for the anterior cruciate ligament? Patella tuberosity. Lateral tibial condyle. Intercondylar eminence. Medial malleolus. The correct answer is intercondylar eminence. 2. The flat surface formed proximally by the tibial condyles is known as the dash. Tibial ridge. Tibial plateau. Tibial eminence. Tibial tubercle. The correct answer is tibial plateau. The fibula. The fibula is a bone located within the lateral aspect of the leg. Its main function is to act as an attachment for muscles, and not as a weight bearer. It has three main articulations. Proximal tibiofibular joint, articulates with the lateral condyle of the tibia. Distal tibiofibular joint, articulates with the fibular notch of the tibia. Ankle joint, articulates with the talus bone of the foot. In this video, we shall look at the anatomy of the fibula, its structure, bony landmarks and clinical relevance. Bony landmarks. Proximal. At the proximal end, the fibula has an enlarged head, which contains a facet for articulation with the lateral condyle of the tibia. On the posterior and lateral surface of the fibular neck, the common fibular nerve can be found. Shaft. The fibular shaft has three surfaces, anterior, lateral and posterior. The leg is split into three compartments, and each surface faces its respective compartment, e.g. anterior surface faces the anterior compartment of the leg. Distal. Distally, the lateral surface continues inferiorly, and is called the lateral malleolus. The lateral malleolus is more prominent than the medial malleolus, and can be palpated at the ankle on the lateral side of the leg. Clinical relevance. Fractures of the fibula. At the ankle, the lateral malleolus of the fibula is prone to fracture. There are two main ways in which this occurs. The first way is by forced external rotation of the ankle. This force of the talus against the bone causes a spiral fracture of the lateral malleolus. The other, less common way, by the foot being twisted outwards, called eversion. Again, the talus presses against the lateral malleolus, and this time causes a transverse fracture. Now let's have a quiz. 1. Which peripheral nerve is closely associated with the EC of fibula? Common fibular, superficial fibula, sciatic, tibial. The correct answer is common fibular. The bones of the foot provide mechanical support for the soft tissues, helping the foot withstand the weight of the body whilst standing and in motion. They can be divided into three groups. Tarsals, a set of 7 irregularly shaped bones. They are situated proximally in the foot in the ankle area. Metatarsals, connect the phalanges to the tarsals. There are 5 in number, 1 for each digit. Phalanges, the bones of the toes. Each toe has 3 phalanges, proximal, intermediate, and distal, except the big toe, which only has 2 phalanges. The foot can also be divided up into 3 regions: I. Hindfoot, talus and calcaneus; E. Midfoot, navicular, cuboid, and cuneiforms; and E. Forefoot, metatarsals and phalanges. In this video, we shall look at the anatomy of the bones of the foot, their bony landmarks, articulations, and clinical correlations. Tarsals. The tarsal bones of the foot are organized into 3 rows: proximal, intermediate, and distal. Proximal group. The proximal tarsal bones are the talus and the calcaneus. These comprise the hindfoot, forming the bony framework around the proximal ankle and heel. Talus. The talus is the most superior of the tarsal bones. It transmits the weight of the entire body to the foot. It has 3 articulations. Superiorly, ankle joint, between the talus and the bones of the leg, the tibia and fibula. Inferiorly, subtalar joint, between the talus and calcaneus. Anteriorly, talonavicular joint, between the talus and the navicular. The main function of the talus is to transmit forces from the tibia to the heel bone, known as the calcaneus. It is wider anteriorly compared to posteriorly, which provides additional stability to the ankle. Whilst numerous ligaments attach to the talus, no muscles originate from or insert onto it. This means there is a high risk of avascular necrosis, as the vascular supply is dependent on fascial structures. Calcaneus. The calcaneus is the largest tarsal bone and lies underneath the talus, where it constitutes the heel. It has 2 articulations. Superiorly, subtalar talocalcaneal joint, between the calcaneus and the talus. Anteriorly, calcaneocuboid joint, between the calcaneus and the cuboid. It protrudes posteriorly and takes the weight of the body as the heel hits the ground when walking. The posterior aspect of the calcaneus is marked by calcaneal tuberosity, to which the Achilles tendon attaches. Intermediate group. The intermediate row of tarsal bones contains 1 bone, the navicular, given its name because it is shaped like a boat. Positioned medially, it articulates with the talus posteriorly, all 3 cuneiform bones anteriorly, and the cuboid bone laterally. On the plantar surface of the navicular, there is a tuberosity for the attachment of part of the tibialis posterior tendon. Distal group. In the distal row, there are 4 tarsal bones, the cuboid and the 3 cuneiforms. These bones articulate with the metatarsals of the foot. The cuboid is furthest lateral, lying anterior to the calcaneus and behind the 4th and 5th metatarsals. As its name suggests, it is cuboidal in shape. The inferior plantar surface of the cuboid is marked by a groove for the tendon of fibularis longus. The 3 cuneiforms lateral, intermediate or middle and medial or wedge-shaped bones. They articulate with the navicular posteriorly, and the metatarsals anteriorly. The shape of the bones helps form a transverse arch across the foot. They are also the attachment point for several muscles. Medial cuneiform, tibialis anterior, part of tibialis posterior, and fibularis longus. Lateral cuneiform, flexor hallucis brevis. Clinical relevance, fractures of the talus and calcaneus. The talus and the calcaneus are primarily involved in transmitting forces from the body to the ground and vice versa. This means they are frequently fractures in high-energy trauma. Talus. Talar fractures most commonly occur in the neck region 50% but can also occur in the body or lateral process. Fractures of the talar head are the least common. Talar neck fractures are typically high-energy injuries where the foot is forcibly dorsiflexed and the neck of the talus is pushed against the tibia. In this type of fracture, the blood supply to the talus may be disturbed, leading to avascular necrosis of the bone. Fractures of the talar body usually occur from jumping from a height. Calcaneus. The calcaneus is often fractured as a result of axial loading, typically from a fall from a height. These patients should be assessed for associated injuries such as fractures of the lumbar spine or lower limb. The bone can break into several pieces, comminuted fracture. On X-ray, the calcaneus will appear shorter and wider. Even after treatment, a calcaneal fracture can cause further problems. The subtalar joint is usually disrupted, causing the joint to become arthritic. The patient can experience pain upon inversion and eversion, which can make walking on uneven ground particularly painful. The calcaneo-cuboid joint can also be affected. Metatarsals. The metatarsals are located in the forefoot, between the tarsals and phalanges. They are numbered IV medial to lateral. Each metatarsal has a similar structure. They are convex dorsally and consist of a head, neck, shaft, and base distal to proximal. They have 3 or 4 articulations. Proximally, tarsometatarsal joints, between the metatarsal bases and the tarsal bones. Laterally, intermetatarsal joints between the metatarsal and the adjacent metatarsals. Distally, metatarsophalangeal joint, between the metatarsal head and the proximal phalanx. Clinical relevance, fractures of the metatarsal bones. Metatarsal fractures can occur by 3 main mechanisms. The most common method of fracture is a direct blow to the foot, usually from a heavy object dropping onto the foot. Another type of metatarsal injury is a stress fracture, an incomplete fracture caused by repeated stress to the bone. It is common in athletes and occurs most frequently at the necks of the 2nd and 3rd metatarsals and the proximal 5th metatarsal. The metatarsals can also be fractured by excessive inversion of the foot. If the foot is violently inverted, the fibularis brevis muscle can avulse tear off the base of the 5th metatarsal. Phalanges. The phalanges are the bones of the toes. The 2nd to 5th toes all have proximal, middle, and distal phalanges. The great toe has only 2, proximal and distal phalanges. They are similar in structure to the metatarsals. Each phalanx consists of a base, shaft, and head. Now let's have a quiz. 1. How many tarsal bones are present in the foot? 3, 5, 7, 9. The correct answer is 7. 2. Regarding the talus, which of the following statements is true? The talar head is the most common site of fracture. Neck fractures usually occur via jumping from a height. It articulates anteriorly at the talonavicular joint. Low risk of avascular necrosis. The correct answer is, it articulates anteriorly at the talonavicular joint. Thanks for watching. Like and subscribe to Anatomy Movement channel for more.